sound come in? Because obviously that doesn't really be conducive for podcasting, does it? But at the same time, it's so hot.
Are you in an attic room, Gandhi?
I'm not, believe it or not. So many people may remember I moved down from the attic in my house into this side room. Well, I am planning on doing something down there that hopefully means I can rejig things so it looks a bit more
Is it the long
YouTube-ish.
room?
It's the long room, as we call
the
it.
long
Yes.
room. Yeah. It sounds really grand, doesn't it? Sounds like
it does.
Lord's cricket.
It's just very long. It's like 9 meters long, and it's only about 2 meters wide. So it is the long room by definition.
I think you could have different zones for different activities in that room. That would work well.
It's planned. I've just as ever got to find the time to do it. Is the problem inevitably?
So people are joining for the traditional soft start for the live podcasts, and I think we've sort of gone live. We've changed the date at fairly short notice, haven't we? With this one.
Yeah. So unfortunately, we had to change it because Google decided to crash. Believe it or not. So, well, not Google, but Google Cloud crashed last time we were meant to go live, and therefore our software that we used for this wasn't working, and therefore as a result of that, we're going live this week instead. It just gave us a bit more opportunity to talk about certain stuff, so it'll be interesting to see how that goes down.
Good.
And we're getting a shout out from Miss Melody back on the podcast. So cannot believe how lovely the weather is lately. Hello, you two. Great to be here tonight. So good to see you as well, Miss Melody.
Yeah, thanks for stepping out the sunshine, Miss Melody, to join us.
Yeah.
Or maybe you're on your phone and you're still out in the sunshine, or who knows? But it's great to have you on board.
I often get told how we join people on their TVs nowadays, Andy. So apparently more and more people are watching us on their TVs.
I'm a YouTube on the TV person, actually. Watch a lot of YouTube on the TV.
Mm-hmm.
Quite like architecture programs and home improvements. That's what's on my feed at the moment.
So you're a grand design man then? Yeah.
Channel 4 have some good archive programs that they're putting on their YouTube channel. So yeah, everyone can check that out.
Cool. All right, I think
shall we get going?
We're going to get started now, everyone. So buckle up as we go through today's episode. There's loads of stuff that's happened in the past few weeks, including the spending review, which obviously directs some funds to the NHS and general practice. We're going to talk about how that's happened and what's happened from there. Confed happened. We're going to talk about what was discussed at that particular event. And then there's been some fairly interesting letters talking about tech changes in general practice that absolutely need our attention. And all that, including the future of this channel as we tech enhance your primary care and learning. Hello, YouTubers. Welcome to this episode. Myself and Andy are giving you a massive update in terms of what's been happening in general practice. And we've got loads to cover, haven't we, Andy?
We have. So I guess we'll be kicking off looking backwards to the spending review. We were supposed to go live last week when this was a little bit more fresh in people's minds, but there's still a lot to say about the spending review and what it means for health. We've got some stories about digital health products that have been featuring on WhatsApp and in the media, looking at Anima and ambient voice scribes. And then I guess we'll be looking forwards into the future because Amanda Doyle has been talking about the 10-year plan at the NHS Confed conference and giving us some insights. And I guess she must have seen it, Gandhi, I guess, as the director of primary care. So so worth listening to what she's got to say about it. So yeah, Definitely. Looking forward to it.
Yeah, it should be an interesting episode. And we do apologize to everyone that we weren't able to go live last week. So there were some issues with Google Cloud last Thursday evening when we were meant to go live. And as a result of that, we just felt we couldn't put out a decent episode because we couldn't use our standard software and stuff. And it literally happened like 10 minutes before we were going live. So for that reason, we decided to go today. There are some other things we're going to talk about in terms of the future of the channel. So you will need to stick with us to hear about that. It's going to apply for at least the next 2 months, so pretty much, because it's going to have some impact in terms of what we're doing. So definitely stick around to hear all of that things. But before we do that, I think we absolutely need to kick off and start talking about the spending review, because this is stuff for general practice, isn't it, Andy?
Yeah, well, health were one of the big kind of beneficiaries of the spending review. So for those people with a short memory, this was all over the news last week. So on the 11th of June, Chancellor Rachel Reeves gave a speech in Parliament announcing details of the long-awaited spending review. So in this, she sort of detailed how she was going to, or how the government will spend some of the money and spending that was identified earlier in the year in the spring budget.
Mhm.
And the way this is presented is in terms of settlements or funding for different departments, and then announcing kind of individual spending sort of pledges or allocations within those departments. And a lot of them were for health. And also just the timescale. So this is looking at spending going forwards through to 2029, which will nearly take us to the next election.
Yeah.
And thanks very much to NHS Confederation. They've done a very good analysis, and we've also looked at some of the other kind of reporting in the media around this to pull together some information for people. So shall we sort of give people the headlines?
Yeah, let's go for it. Do you want to go through that, Andy?
Yeah, I'll go through it, and then we can kind of discuss what we think it means, really,
Yep.
and also the context within which this comes, I think, is important as well. So the headline for us, I guess, is that the Department of Health and Social Care gets an increase of 2.8% in real terms. So that's over and above inflation over the course of the spending review. So that's annually 2.8% over inflation, running through to 2029. I guess just flipping to the Guardian article, some of the other headlines that people are talking about, just to give it sort of context, is an increase in defense spending as well, increases in spending to support border security activity. So this is all kind of you can see how the politics, I guess, is behind some of this as well. People remember there were some big announcements on energy, so small modular nuclear reactors, moving forward with some of the bigger nuclear power programs, and also carbon capture. There was some mention of the support that's already been pledged for steel, and support for entrepreneurship and business, and a big announcement on social housing as well. And I think since then we've had further announcements about how that 39 billion for social housing will be spent. And I guess when we look into some of the other announcements, there were some that were kind of health adjacent announcements, so things that are not necessarily directly to do with health, but that support the wider determinants of health. So things like housing, education, things that affect availability of work and things like that as well. So I guess getting back to the health announcements. So I guess the big announcements around health were, so apart from the headline budget, and so a lot of the details about how that will be spent, I guess we're waiting for in the 10-year plan, and that will be coming out, what do we say, 7th of July, I think Amanda's.
So we don't know when the 10-year plan is due to come out. However, because the 7th of July is the NHS birthday, we think it's likely to come out on the 7th of July, given the fact that that's the big date that's coming up shortly. And what a time to release, a 10-year plan for the NHS, but on its birthday. So
absolutely. So assuming the government is organised enough to have everything shipshape and ready to go for that date, then maybe they'll use it to announce the 10-year plan. So headline health announcements are 10 billion in NHS technology and digital transformation by 2029. So that's obviously 10 billion total spending over the course of the next 4 years. That's an almost 50% increase from 25 to 26. So supporting things like development of a single patient record, supporting the NHS app and expanding functionality within the NHS app, and continued adoption of the federated data platform. Do you know what that is, Gandhi?
So the FDP is this this thought of basically having a unified repository of information for different areas to look at and utilize and use. Kind of think of it like Mastodon for the NHS data.
Okay.
So
a secure APIs can kind of access the data and present it to you in different ways. Yeah.
Effectively, yeah.
Okay. Additional funding by 28-29 to train more GPs, although a specific funding figure isn't provided within the announcements. Allocation of funding for 700,000 additional urgent NHS dental appointments over per year over the spending review. So did a little bit of digging, and the NHS BSA, so the bot that deals with dental treatment, says that there are about 34 dental treatments delivered per year. So That's, I guess a 3% increase on top, so not insignificant. A commitment to expanding mental health support teams to all schools in England by employing 8,500 additional mental health staff by the end of the Parliament. So that's quite specific, isn't it? Um, and Google tells us that there are about 24,500 schools in England. So one can see how that number of full-time equivalent staff may have a fairly significant impact on people well-being. Some of those schools will be small primary schools. Mental health support might be concentrated, maybe in secondary education. I mean, who knows how they'll be distributed, but it's not an insignificant number compared to the number of schools. So that's interesting. Any thoughts on those headlines before we move to those kind of health adjacent things, Gandhi?
So it talks about big sums of money. I guess like we always talk about the devil's in the detail, and we won't get that till we get the 10-year plan, I suspect, in terms of where some of their direction of those funding will go. But yeah, always resources good, I think.
Yeah, absolutely. I think there's a lot of money that additional money which we're not being told where it's going to go. And I suppose, and when we come to a little bit of our kind of thoughts on this, I know we've drafted out that actually it's not necessarily a huge amount of money when accounting for wage increases, inflation, increases in costs of delivery, an aging population, a population that's becoming more unwell. It may a lot of this won't all be available for transformational change, and actually just sort of keeping going, keeping the lights on will take a lot of this additional funding, although the NHS does quite well compared to other areas of government that will see real-time cuts. So kind of other announcements within the spending review that may be relevant for health are so for an additional an increase of over 4 billion funding available for adult social care. So this is by the time we get to year 28-29, there will be 4 billion more annually available for social care. Integrated settlements will be expanded to 5 further mayoral strategic authorities. So that's more funding for mayoral authorities, and they look at things like the environment that people live and work in, local sort of development and improvement and regeneration strategies, transport. So these are things that can improve people's wider determinants of health. A 100 million investment in community help partnerships to bring together a range of services to benefit and support adults with complex needs. So I guess that has to be balanced with some of the cuts to benefits and so forth for people living with disabilities, but that's an announcement for some more funding. 410 million per year to expand free school meal eligibility to all pupils in England with a parent receiving universal credit. So some children that don't currently get a free school meal will get one. Increase in R&D funding, so that might result in better treatments further down the line, more clinical trials. That's 22 billion per year, and this includes 500 million for an accelerator program to get additional private investment into innovation. Now, this isn't necessarily health innovation, but some of it hopefully will be. 410 million for local innovation partnerships, and then over 2 billion to drive an AI action plan, including a 20-fold increase in support for compute capacity. So these are things that don't necessarily directly affect health, but one can see how some of the wider effects might support development of health technology and supporting people with a wider determinants of health. So those are the main announcements. Blown away, Gandhi, or how are you feeling about those?
I mean, the numbers sound great and significant and large and things, but I think it's challenging to understand what impact they're going to have in terms of overall healthcare. I think the ones around, the school placements that we heard earlier, you can see the impact they may potentially have in terms of supporting, children, patients, etc. in terms of overall things. These ones are more, it feels like more, like you say, more adjacent stuff that's not going to have a direct impact, but potentially have some, the school meals in terms of nutrition for some of our, children deprived areas. I think that's a really powerful thing to do. And, it seems like they're trying to do something. The AI action plan, I'm a little bit confused about how that's going to work effectively, given they're putting so much money into that compared to some of the other ones. And is that because of the fact that obviously AI just seems to cost a lot of money?
I think it's part of the general industrial strategy
Mhm.
for for general development of the economy and the country, but it's considered, I guess, supportive of health innovations as well, and I guess may improve, give people jobs and things to work on, which is good for people's health, I guess. So, if it benefits the
Mhm.
general economy. So yeah, but interesting announcements. Uh, so what the Confed said is, well, actually, 2.8% is a good amount of annual real terms increase, but
Mhm.
actually historically, and I think going back to the beginning of the NHS, the average annual increase is 3.6%. So actually, it's less than the average annual increase over the
Mhm.
lifetime of the NHS. And the Health Foundation, who we often look at some of their material on the website, say that actually a 4% spending target would be required to just restore services to the state that they were in sort of pre-COVID and in previous years. So not necessarily transformational amounts of money. And I
No.
think the bigger details of how it's going to be spent, we're waiting for in the 10-year plan.
Mhm.
I've a new website and podcast that I've been enjoying. Comes from the Institute for Government, which sounds really, really boring, but they do some great material
Okay.
about government sort of governance and spending. It's really, really interesting. But they had some interesting graphs anyway, so we'll put this in the show notes. But some interesting graphs. This just looks at the spending over the last few years and projected spending in the
Mhm.
next over the course of the spending review for different departments, sort of starting at a zero baseline, sort of 15 years ago in 2010, 2011. And it's did I say like the winners and losers. So Department of Health and Social Care, winning, DEFRAS, that's environment, farming, and so forth, winning, so Her Majesty's Treasury and Her Majesty's Revenue and Customs, positive increases, Department for Environment, Home Office, and then interesting, MOD, despite the announcements, actually seeing a reduction over that period of time
Mhm.
in
They're bringing
day-to-day
them back
spending.
up by the looks of it, back up towards the baseline at the very least, compared to some of the
Yeah,
others, which are much lower.
yeah. So just highlighting that it's not winners across the board, I guess. And then there are a few more graphs which are interesting. So this graph is intended to show the changes in spending year on year. Let me just remind myself. Average annual returns change in day-to-day spending funding between 24-25 and the end of the spending review in 28-29. So it's just interesting to see actually. And one of the big projected beneficiaries is general practice in
Mhm.
terms of spending, with bigger increases than other areas. And interesting, it separates out hospitals that are looking at a slightly lower increase, and you can see sort of prisons and courts suffering over the course of the spending review.
Mm.
So anyway, just interesting and good podcast. If people want to check them out, search for Institute for Government on your podcast app. There's a good interview with Jeremy Hunt. He's peddling his new book at the moment, so it's interesting. But he's an interesting
Okay.
chap with interesting insights. So that's the spending review. I mean, I had some thoughts really. So interesting the context that it's kind of come within. So actually, in terms of general practice, we've just had a 8 point something percent increase in our global sum in terms of the recent GP settlement. Then there was the 80 million for advice and guidance on top of that as well. I think looking at nearly 900 million increase for general practice in the last
Mhm.
contract. That was allowing for the 2.8% projected GP pay uplift, but that's now 4%. So some of that additional funding is going to be going to pay for that. Just thinking more widely in the context of the NHS, minimum wage increases have been quite high. I think 6.7%
Mhm.
in general, and 16% for 18 to 20-year-olds. And we've got the ICP running costs are being cut by 50% as well. So we have those. Gosh, and the department, and actually NHS England is being forgot. NHS England is disappearing within
Yep.
2 years as well. So there's just a huge amount of restructuring, happening amidst the modest spending increase. So I just wonder if this level of spending increase is really consistent with the transformational change that is being discussed, given the amount of restructuring that's necessary, and whether.
And I think that's the part that everyone's waiting to hear, isn't it? In terms of what does the 10-year plan suggest in terms of this constant, almost, well, near constant reorganization that we're dealing with in terms of what's happening within the systems as the ICBs move up. And we talked about that, previous episodes, as we get these new organizations, integrators, as well as neighborhoods filling in the void of the ICBs, becoming more strategic, with places becoming part of that as well, with PCNs serving some sort of mix within that as well. And this whole mishmash of provider collaboratives and various other organizations, it's going to be an interesting space to figure out where people are, isn't it, Andy?
It is. I'm really looking forward to the NHS 10-year plan to provide some guidance in terms of what we should be working towards, because there's all sorts of different sort of models and ideas at the moment, and I hope we get some guidance. But we will, we will see. So hopefully that was a helpful look and our take on the spending review. Maybe time to move on to the next story. Is it to do with AI, Gandhi?
Well, there's different ones talking about AI. I think we were going to first start off with the AVT one. So this is the ambient voice technology. So this is covering some guidance that came out a couple of weeks ago. Now, some people may remember from a short while back, we had a letter from NHS that basically suggested to use AVT in detail. And particularly, it was one of the sound bites that Wes Streeting made about how the technology can help healthcare, and in particular hospital and primary care, manage patients more effectively and safer and stuff. And then we had this letter came out just last week on the 9th, just over last week on the 9th of June from NHS England, which actually is one of the first formal pieces of guidance around the use of AVT in terms of healthcare. And it basically set out the terms of use for AVT in general practice, which I think shocked a lot of people, because the reaction from this was for many places to turn around and say, don't use it, which is not what the letter says.
It's complicated, isn't it? There's quite a lot of requirements that people need to be satisfied are met. So I guess if people are not confident that they've met these requirements, they're going to put things on hold or pause them, aren't they, Gandhi? Can you provide any sort of guidance? Because I would gather you're a user of these technologies at your...
So I think what the letter outlines is that basically you need to, and this is something I've been saying repeatedly when people ask me about AVTs, you need to have done your due diligence in terms of the technologies and the products and how they work. So effectively, you need to have done all the data governance, like the DTAC assessments, in terms of the data technology assessment criteria. You need to have checked the security aspects in terms of the DSP toolkits and the CREST certificates, the penetration testing, and all that kind of stuff. That basically means that the product is digitally safe. Okay. It then talks about having to have checked, data protection impact assessments, which therefore means the flow of information is safe. And that's something the practice needs to do. The provider can help you do that. And there are template versions for certain providers, but you still need to analyze and evaluate that for yourself. And then you need to do the clinical safety aspect of it, which is the combination of the two parts, which is the DCB 0129 and the DCB 0160 documents. Basically look at the clinical risk of the product and how that works or does not work if that's the case. And then there's other things that absolutely need to be in there. So obviously it needs to be GDPR compliant, needs to be encrypted, needs to integrate within the systems appropriately if able to do so. But then the key thing that came out was this concept of medical device classification. So for many, many months, many people have been talking about the fact that is ambient voice technology a medical device? Because if it is, it needs to be held to the standards of being a medical device. And the long and short of it is, if it's a product that just does summarizing of the notes, the general thought is that is a class 1 device. So that's a level of certification that they need to have approved with the MRHA, Medicines and Health Regulation Agency and stuff. And then they can be used. But effectively, NHS England is saying that you should only use products that have at the very least, class 1 certification if all they're doing is summarization. Does
I had a
that
look on
make
the
sense?
MHRA. Yeah, I had a look on the MHRA website because I thought, I need to be reminded what sort of what a class 1 device is, what a class 2 device is, what a class 3 device is. And it was interesting. A class 1 device is lowest risk category, as it's sort of syringes without needles, medicine spoons, spectacle frames, standard adhesive bandages, examination lights. So it feels, I mean, obviously those things, they need to be safe, and there are ways in which those things could be unsafe. But I just thought it was interesting because the complexity of what it does is far in excess of those things. Just
absolutely. And I think that's one of the things that's confused many people, and also then in this whole question mark around AI and particularly ambient voice technology in healthcare, in terms of where does that level sit. But effectively the answer seems to be, if it summarizes and only summarizes, it now needs to be MRHA class 1 at least. If the product does more, so if it suggests diagnoses, if it makes inference, if it starts doing a little bit more complex stuff, then at the very least it is a class 2A, and therefore the level of certification process and governance that comes with that is considerably higher. And as far as I'm aware, there is currently no ambient voice technology that has class 2A certification or higher.
And class 2A is short-term. Examples include short-term corrective contact lenses, suture needles, standard hearing aids, and TENS devices. So I guess those are examples, but I guess it's talking about kind of the certification process that they need to go through. And I guess that's going to be sort of different and have different levels for the different classes. And maybe those examples on the website are a little bit out of date. Highest classification is class 3, which is things like pacemakers, joint replacements, breast implants, things like that.
And I think maybe we need to start seeing a bit more explanation in terms of what a classification 1, 2A, 2B, 2C is when it comes to technology, in terms of examples. But at the same time, this is where, there's been a lot of uncertainty in terms of what this means moving forward. But this document basically says, do your due diligence and make sure it's class 1 certified. And if you do that, you should be okay to use it as long as you accept, and this is the last part it finishes off, as long as you accept the risk of using it as well. So it clearly puts the risk of these technologies back on the practice users, not absolving them of the risk from that perspective. And I think that will make many people uncertain. That's why I think a lot of ICBs have turned around and said that they won't use these, because that's putting the risk back onto the ICBs if they've approved it. But I think as long as the practice, as you've done your due diligence and the product is safe, it should be okay.
Yeah. So I guess, Gandhi, a lot of these steps sound a little bit intimidating. You've obviously gone through them as a practice. So I guess once you get started doing your DTAC, your DSPT, your data protection requirements, is that actually fairly simple once you get started?
I think these are things that take time is the first thing. They are not something that you can do at a whim by any means. So to do a decent DPIA, to be honest, you're talking at least a good week or two's worth. It's not
that's one person sat down working for a week or two, or
pretty much, to do it properly, because you need to evaluate different aspects of things. I think there are tools that can help you do that, and using templates can massively speed up a lot of that, particularly if you're doing it from a new perspective. But you need to figure out how the data flows in your practice. So you need to understand the processes in your practice and what tools you're already using, how they impact that. And that's where it sometimes takes time, because you then may start doing and realize, I don't know what this does. I can't remember this process. So I now need to figure out this process. And that's where the flow issue can sometimes be. The more technical stuff like the DCB 0129s, that should be provided by the provider. There's also hazard logs as well that you need to look at in terms of their risks, where they know they've got some risks, because everyone's got an element of risk. Anybody who's got an empty hazard log, that's a worry for me, because that basically says that they're perfect, and nobody's perfect when it comes to clinical risk.
Because there's a link here, isn't there? I remember, we maybe need to put it in the show notes, because I'm sure that we have gone through the link to document here, which is a bit more of a step-by-step
I need to
guide,
zoom in, Andy.
Walks people through the implementation guide for putting these things in place in a bit more of a 1, 2, 3, 4 way. It's a longer document than the letter, but it seems
might need to zoom in on that one, Andy. It's quite small.
Let's zoom. So it's linked to from the letter, but it's sort of a quick implementation guide, and it walks people through the process. So that would be a good resource for people to go to and take a look at.
Definitely. So I guess hopefully this looks at some of those challenges that people have had. I think, as long as you've looked at the security and stuff of the different aspects of things and addressed it, I think, there is still this opportunity for people to use ambient voice technology in general practice. And one of the things to remember is these technologies, when used properly, can be really significant in terms of the impact that they can have in terms of clinician usability, productivity, and, to be fair, burnout as well. So, they are technologies that could have real potential to help, but as long as they're used safely.
Yes. There's a few more AI stories that have been surfacing.
Yep.
Merseyside Medical Practice have had some issues with Anima. Published a letter which has done the rounds, and I almost thought that this was from Merseyside LMC when I first saw this letter, but actually Merseyside are I think just north of Cambridge, and they're sort of a large group practice that has multiple sites, I believe, and they've written what is actually quite a technical letter raising concerns about Anima, who provide a AI-driven medical letters summarizing platform to their local ICB, and also copying in Katie Bramall-Stainer, who is Chief Executive of Cambridgeshire Local Medical Committee and also Chair of the BMA GPC. As well.
Yep.
So it's an interesting letter. I mean, do you want to talk us through the controversy here, Gandhi?
Yeah, so I think that this letter outlines a few concerns and criticisms, to be fair, as well. I think we can use that word. It's quite strong in terms of, the data governance of products held by Anima, specifically the document processing aspect of it. It seems to focus on that rather than other parts that Anima provide. So remembering that Anima also provide online consultation platforms, ambient scribe technology, but this is specifically around their document processing product. Talking about their I'm1 integration, so the system, think of this as the cable that allows them to connect with the EHR, so System 1, EMIS, etc., and things, and how it integrates within that. That's probably the easiest way of thinking about it. So how they have that access, and whether, effectively saying that they are using their data governance from their other products, which have been approved and around for a longer period of time, and using that to justify their document processing product. And concerns around transparency in terms of communication and various other comments and stuff, which, it goes through in the letter. I think when you read it, it comes across as quite damning in some ways. I think there's also one part that I found a bit weird with reading this letter. Can you figure out what that might have been, Andy?
Which bit was it?
So it's a bit lower down, and it's the one part where it seems to then specify another provider a preference of use, which I think for me, if I'm reading a letter that's meant to be alerting to a concern around a digital product, I wouldn't then typically be trying to identify another provider to be pushed forward or to prioritize or that kind of stuff. Maybe other providers possibly, but singling out one. Now, I guess at this point, while Andy's reading, probably a good time for me to do this. I'm going to have to give a clear declaration for me personally on this. So I am with the EGP learning, the technical stuff that we do in terms of the provider demonstrations and that kind of stuff. I have worked with both Anima and Better Letter, two companies who commented in this, and have been sponsored to work with both of them in the past as well. So just to be clear on that point, and I have worked with both of these providers and been sponsored by them as well on the channel. And many of you may have seen some of that content and stuff, over the past few months and things. But I think it just seems a bit weird that in the same letter, whilst they want to comment and criticize on the data governance, they're then pushing forward that another provider's pushed ahead, which, there are absolutely frustrating delays that happen with providers having to get assurances for various different things. Like I know for many providers, getting NHS app access is really a frustrating process, and also getting access to the system providers in terms of integration can take a while as well. but it just seemed a bit strange that was prioritized as part of the letter to me.
Yeah, just digesting that, Gandhi. So I guess what they appear to have, so this is going to be pure speculation on my point, but they mention, okay, large number of practices have already signed up to Anima's document processing. They talk about a lack of choice for practices in AI processing, which is interesting because there are other products on the market, include a better, and they've identified better letter that they feel is superior, or at least in their kind of their governance. And so forth. So one wonders. I mean, is and this is written to the ICB and the local LMC. So one wonders if there's a situation locally where one provider might have been perceived as being favoured by the ICB over another, and perhaps funded or something like that. And it might be, as well as the data management concerns, that there are concerns over kind of procurement and how level the playing field has been for different providers in the area. Maybe I don't know. It's pure speculation. But I guess anyway, Anima have responded. So do you want to move to their response?
Yep. And I guess just to comment from both providers, I think both providers are actually really good at what they do. So in terms of the product itself, I've demonstrated them on the channel actually about 6 weeks ago, I think it was, had a comparison actually between the two providers along with 3 other providers when it comes to document processing at the same time. But yeah, the response from Anima came the following day. So I believe, the Meriside letter came out on Tuesday. This letter came out yesterday from Anima. And it basically challenges every aspect. So this clarifies from Anima's perspective that actually they do have the appropriate IM1 and documentation and guidance, and it is specified for their document processing product itself, that they are GDPR compliant as per the guidance. And often these product companies do have their document testing and stuff challenged on a repeated basis. Almost every single time they have to go with a new client, they will have to demonstrate that they've got these certificates and products and stuff and things, and they have gone through the relevant compliance frameworks. In fact, they feel they've gone even above that, going to the next level. They mentioned about using the check standards instead, which are considered to be slightly higher than some of the ones commented in the letter itself. And they're quite clear that they feel that the practice that has mentioned this never actually continued with the sign up of the product, that it was offered to free to them because they decided to back out as well. So they haven't paid anything. There was no data integration in question. So there is this whole question of, it seems like, how do I put this? An issue between a provider and a practice that hasn't gone well for whatever reason and has become very, very public. And as a result of that has been shared multiple times. And because it focuses around AI and some of these other aspects, pushing along the lines of, is this appropriate? Is this safe? How should we do this? I think from speaking with several other people around this, it has raised questions around, as ever, the use of AI in healthcare, because it's still the Wild West and people are still uncertain as to the overall safety of some of these aspects and things. But also, I think there's an aspect to, as ever, there are 2 sides to every story. And we don't know what's happened in those rooms and the stuff directly. But I think people should always make their own independent decisions on products and look at the guidance themselves, rather than necessarily, from my view, taking the information from just one side of a story.
Yeah, I guess the message here is, I guess do your own diligence and reach your own conclusions. I guess.
Yeah.
Although, and it's a difficult landscape, isn't it? Because we're not experts, most of us in these areas, and we often do rely on information from colleagues as well.
True.
But I guess that toolkit that we talked about earlier and referenced in the AVS letter is there, and I guess people ought to be working through that as they're beginning to sign on to AI providers, and that's the right process to follow.
Absolutely.
Okay.
I think ultimately, for me, as ever, I want to comment on obviously the role that we kind of play in some of this. That's all right, Andy. So, obviously me particularly, I show a lot of providers to primary care to try and demonstrate what exists out there. I repeatedly say to people, there is no best tool. There is the best tool for you in terms of what you look at, your practice, what works with your systems and processes and things. And I think it's important that people do take care and attention to look at the documentation, ask to see the governance and the details. And I know sometimes it can feel intimidating and scary and stuff, but actually that is part of running a practice. It is your responsibility to make sure it is up to snuff. I'm fortunate that work in a practice where I've got other people to help me do that as well, and that's where discussion on these things can help. So discussing it with other people, practice and stuff, can absolutely help. And I think for me, both providers in those letters are, from my perspective, decent providers. I think there is a question of why this went so wide so quickly as well, in terms of the commentary. But I think hopefully it can all be resolved sensibly and appropriately and dealt with. But it did cause a fun storm for those watching us.
Yeah, why do you think that happened? Do people just like the drama, Gandhi?
I don't know.
I guess people have legitimate concerns, and it's a hot topic, and people are making those decisions at the moment. So I guess those are good ingredients.
It is a very topical area that people are uncertain of, because there is no formal frameworks, no formal guidance as such, in terms of particularly document processing when it comes to AI. And I guess there are absolute concerns. But I think, we live in a world where the tech will now always move faster than the governance that exists to modify it and stuff. And the question is, do you follow the existing governance that's out of date potentially, or not address what technology can now do, versus try and do more with less? Because that's what we're all trying to do right now, try and do more with less. And how do you manage that in a world where you're still repeatedly then asked to do even more?
Yeah, it reminds me of some of the kind of earlier work that we did when we were looking at things like, where is your organization and you on the change curve, and actually when are you choosing to adopt these new technologies, and are you in the right place as an organization? Do you need to be an early adopter? Are you positioned to be an early adopter? Can you wait, let others blaze the trail, or are you equipped to do that? So yeah, interesting, just making me reflect on some of those earlier pieces of work that we did. So, okay.
Speaking of change, how about now we talk about some of the changes that are going to come to the channel for those of you that are watching?
Let's do it.
Yeah, let's do it. So I guess we wanted to cover this just in brief, because there are going to be a couple of changes, partly because, if you can believe it or not, I'm actually going to be away for a couple of weeks. So I'm going to be
unplugged from technology.
Well, yeah, pretty much. So I'm going to be abroad. I'm not going to have any of my streaming kit and stuff. And although technically I could possibly stream, it's not going to be a great experience, and I'm going to be busy, to be honest. So, so for a couple of weeks, just over a couple of weeks, and because of the timings of it, it works out being 3 weeks in terms of our broadcasting schedule and stuff. So Andy's going to be going live without me in a couple of weeks' time. The reason why we're mentioning this, as we mentioned earlier, is we're anticipating that the 10-year plan is going to come out whilst I'm away. And I guess it's this theme, isn't it, Andy? Whenever I go on holiday, something big drops, pretty much.
Yeah, it's sod's luck, as they say, I guess. Or maybe NHS England have access to your calendar. And
maybe they're just trying to make sure we don't cover it and stuff. And whilst normally we've still been able to adapt and manage that, unfortunately, I'm recognizing this time that's probably not going to happen. So I guess on that basis, we are planning preemptively to cover the 10-year plan on July the 17th. So I think Andy's got the thumbnail somewhere for people to have a look at it if they want and things. But effectively, this is what we've already loaded it up. So you can, it is possibly West Streeting. I cannot confirm or deny that that's a likeness of West Streeting there. But, if people want to, they can go and, absolutely subscribe, click the notification so that when it goes live, you'll be able to see our coverage of the 10-year plan. And we are thinking by the 17th of July, it will definitely be out. In fact, it may have been out for quite a while at that point, and we apologize for this delay. I know many people know that we cover these fairly quickly, but just realistically, it's not going to be until then that we manage to do it. And obviously, if it's not out, we'll just delay it and stuff and things. Andy, you're going to say something?
No, I was going to say, well, I mean, we can do we'll be doing some kind of coverage of the coverage, I guess, as well. Sometimes it's nice to let things settle for a few days, see how things have landed. Sometimes we'll follow up stories. So I think we'll still have something fresh to say when it comes round. And you know what, it might not have dropped by then either. So so we'll see. But we're just planning ahead in view of Gandhi's travel plans.
Yep. So, and I guess just In addition to that, in July on the channel, we're going to be covering a few extra things. So particularly some live streams with TPP, looking at some of their products. So the auto review product that they have, which will be on the 16th of July, and then the AI in System One. So we've talked a lot about AI. So System One have some AI stuff that they definitely want to share in terms of appointment mapping and planning and stuff, in terms of clinical health issues and a clinical assistant. So we're going to be covering that live in the webinar on the 30th of July. So that gives you a few things to look forward to: 16th, 17th, and the 30th of July for webinars and live streams that we're going to be covering on the channel. And throughout that, you're going to see some other content coming up as well as ever on EGP Learning to help support you in there. And then the last one that I wanted to talk about as well is our event, Andy, that we're doing in combination with Modality, which Andy probably doesn't have queued up because I forgot to tell him about that.
I don't have a thumbnail for that one, Gandhi.
No, but for those that do know or don't know, so we're doing a joint event with the Modality Partnership in September, on the 9th of September in Birmingham. Digital integration event. If you want to sign up, please do so. So there's the website is bit.ly/mpdigital25. We've already got an amazing agenda planned for this. It looks absolutely awesome, and I can guarantee you're going to have an awesome event. This is very much designed for the more tech-abled, I'd probably say, for those people interested in, products, commissioning and using of them and that kind of stuff. We've got about 150 people already signed up, I believe it is, out of the 200 capacity. So wow. If you want to come, you're going to have to register fairly quickly, because otherwise you may not be able to. And we are trying to look at whether we can live stream it, but the venue is rather special and rather interesting. So we're just making sure that that's going to all work properly for everybody so that they can engage through that route and stuff first of all. But yeah, definitely looking forward to that. So some cool stuff coming up on the channel for all of you.
Good. And I guess the final story today was looking forwards to the 10-year plan, which we'll be covering when Gandhi is back from his break. And, one person who ought to know what's happening is Amanda Doyle, Director of Primary Care at NHS England. And she had some things to say at NHS Confed a week or so, a week or two ago. So shall we just have a quick look at that story and see what we can kind of lift from it in terms of what might be coming. So we've gone to the short story in Pulse, reporting on the talk that she gave to the NHS Confed conference in Manchester, probably about a week ago now. And so anything that jumped out here, or shall we walk through it?
Well, so feedback I've got from people who were there seemed to say it felt like they were trying to say something without being able to say something. And I suspect... Well, I suspect this is because the 10-year plan has been delayed. I suspect the 10-year plan was meant to have come out before Confed so they could talk about it at Confed. And then unfortunately, obviously, because it's not been released, they can't talk about it until it's out. So absolutely, you would imagine that Dr. Amanda Doyle has seen the 10-year plan, being the Director of Primary Care and then involved in its creation. But because they can't talk about it until it's released, it was felt like it was... Yeah, and maybe that there's some hints in this. So if you hear what she says, very much talking around the fact that, there is going to be investment to general practice, but...
but it won't include huge shifts of funding from secondary to primary care immediately. So it's interesting. It will be GP-centric, but won't include huge shifts of funding. It's interesting. It's likely to be launched on the 7th of July. So if they keep to that time scale, then your predictions will be right. Any shift in funding will require new ways of working. Interesting.
Which, to be fair, we've heard from Wes Streeting repeatedly. He has said previously that, there's not going to be new money without change. We've heard that from both, our Prime Minister. We've heard that from Wes Streeting. They've all mentioned about the fact that they're expecting some sort of change to happen in order for funding to be realized and utilized and things. But
I wonder what the change will be. Very GP centric without huge amounts of funding. One wonders if that will be welcomed in general practice, where it has to do things differently and change and transform without much additional funding. I think the future is positive, but we are not going to have more money to do more of the same in the same way. We will never have enough money to meet demand coming through from our aging multimorbid patient population by just doing more of the same. So it sounds like there's definitely an ask to do something different. We absolutely have to accelerate some of the innovation we've seen around the access space, and to the whole raft of how we deliver care across primary care. I think we've got to innovate at scale. That's interesting. If we are designing a model from scratch, it would not look like it does today. We need a significant increase in capacity of our primary and community teams to meet population needs. Interesting without the context of funding. And to do that, the left shift of funding when it comes is not going to come with a bag of money for us saying, here you are, put all of that into primary and community, and then funding will have shifted left. It's interesting.
I mean, that kind of smacks a little bit of work harder and you might get paid for it down the line.
Yeah, I was interested. Do you have any sense of what the mood in the room was during this? Because I'm not sure this sounds entirely positive, but
no. So my impression of that particular session, from what I've heard from people, and this is purely through social media, which is absolutely reliable, as we all know, was that it was fairly negatively taken by many of these general practitioners in the room. You can understand why, if they're being told that, well, you might get some more funding to do more stuff, but you're going to have to do the stuff first, and then we may shift the funding after that, which is it's a frustrating situation, I think, for many people to hear, because actually repeatedly general practices are doing more and more work, but actually we're not seeing the resources follow the funding at this point in the same way that I think a lot of the workload is actually flowing already.
Yeah, it's hard to see that approach really getting the results that they want, to be honest. So we can't just shift from a very cute model to one where, as if by magic, neighborhoods are perfect and community services are scaled up. But we can do it a bite at a time. Some of it will be payment mechanisms we do at the center, but some of it will be hard graft. This is interesting about size. I think size matters, however much we wish it doesn't. I think it does. While we are absolutely committed to protecting partnerships, we've got to think about how we commission on a bigger scale. So that sounds like commissioning services at a scale larger than practices, maybe neighborhoods, maybe primary care networks. So it's interesting. I guess we don't know the details, so speculation. So, but it's interesting that it doesn't sound like there's transformational amounts of money, but there are transformational aspirations, and the mood in the room was not great, I'm hearing. So we wait with bated breath for the
as ever
real announcements within the 10-year plan, and hope to bring you that on the 17th, and hopefully that's whet people's appetites.
So if you want to join us for those episodes, absolutely feel free to do so by subscribing, and then click the little bells next to the episode. It means you get notified, and actually then you know when we're going live directly. And hopefully I'll give you the information that you want to know about things like the 10-year plan, like various other pieces of AI in general practice as well. As ever, Andy and myself are going to be here to just continue to try and tech enhance your primary care and learning. And we will catch you in the next episode. After me holiday. Bye.